And here is your question. Right, so if you have read and understood considering this surgical and augmentation, kindly tell me what is the region you are looking at in picture A and what are the boundaries of this region?
This is the upper 1/3 of the thigh.
Yes.
I'm looking at the
what are the
femoral
boundaries
triangle.
of yes? What are the
Yes.
boundaries of the femoral triangle?
Triangle. Here boundaries are formed by 21st is sartorius. Number 2 is adductor longus. So basically, I am looking right thigh. It's a right thigh.
Yes.
Anterior aspect. Second is adductor longus. 21st is sartorius, and 10th will be iliacus. It will be iliacus. Then structures in this are femoral vein and nerve. So femoral vein is at the level of 8 is femoral vein. And 6 is femoral artery that is leading to branches. And 7th is
can you tell me the contents of the femoral triangle quickly, please?
Yes, ma'am. Content of the femoral triangle are inside the femoral triangle. There is a femoral sheet. Medially, there is a femoral canal, and medial in which lymph node of Cloquet will be there, and fibrofat tissue is there. Medially femoral vein, artery, and lateral cutaneous nerve of thigh. These all present within the femoral sheet. Lateral to the femoral sheet, there will be femoral nerve. Femoral now, sorry, within that there will be genital branch of genital femoral now. Lateral to that will be femoral now, and lateral cutaneous nerve of thigh.
Can you please tell me how the femoral sheet is formed?
Femoral sheet is a funnel-shaped structure. It is basically continuation from the abdomen. Anteriorly, it is formed by the fascia transversalis, anteriorly, and posteriorly, it is formed by the fascia iliacus, and it covers the upper 1/3 of the vessels. At the level of 1/3, the connective tissue of the vessels form this sheet, and they'll get merged there. And this femoral sheet consists of medially femoral canal, and vein and artery, and genital branch of genital femoral nerve.
Yes. Can you please tell me what is adductor canal? And what exactly is the location of it?
Adductor canal is exactly located from the 2/3, upper 2/3, from a line joining the ASIS to adductor tubercle. So adductor canal is also called as subsartorial canal or Hunterian canal. It is formed at the level of apex of the femoral triangle, and it continues up to the Popliteal fossa. So here there is anteriorly anteromedial, anterolateral, and posteromedial, and roof. A roof is formed by sartorius. Posteromedial is formed by adductor longus and adductor magnus. Anterolaterally, it will be vastus lateralis. Contents will be contents will be superficial femoral artery and superficial femoral vein, and also saphenous nerve and long saphenous vein.
Nerve to vastus media as well. Okay, can you please tell me?
Vastus medialis.
Can you please tell me the origin and insertion of sartorius muscle, please?
sartorius muscle, it originates from the ASIS and
No
get inserted.
abbreviations in exam, please. Anterior superior iliac spine, because yes.
Sartorius originates from the anterior superior iliac spine.
Yes.
And it traverses the entire anterior part, anterolateral of the thigh, and it inserts at the level of at the level of adductor tubercle, or below at the level of tibial condyle. Sorry.
What is the nerve supply of sartorius muscle?
Sartorius muscle nerve supply will be I'm not sure, ma'am. It can be femoral now, I think so.
Okay, we'll come back to this question later. This should be your answer. Would you be able to tell me or identify the structures in picture on the left-hand side, please, quickly? Or we can come to this one later.
Yes, ma'am.
Sorry? Are you telling me or we can come to this one later?
Yes, ma'am, I can tell this, ma'am. Basically, we are...
Okay, picture
left side and right side, both are different or the same pictures?
This is your mock exam. Okay, can you please tell me what are you looking at right now?
Okay, ma'am, I'm looking at the popliteal fossa.
Yes.
In the popliteal fossa, right and superiorly, it is formed by 11 number is semi-membranosis, 12 is semi-tendinosis, and again 11 is semi-membranosis. This forms the upper medial part of this. And number 1 is biceps femoris. Biceps femoris.
Can you please tell me the origin and insertion of biceps femoris muscle, please?
Yes, ma'am. Biceps femoris muscle has a short head and a long head.
Yes.
Long head originates from the ischial tuberosity, and short head originates from the proximal part of the femur. And
what are the nerve supply? Yes, please. What are the nerve supply of the biceps femoris muscle?
Biceps femoris supplied by tibial nerve, ma'am.
Both heads? No. Okay, can you please tell me the contents of the popliteal fossa?
Yes, madam. Contents of popliteal fossa are popliteal artery is the deepest content. There will be popliteal vein. Then there will be tibial. Then there will be a tibial nerve and common peroneal nerve, and there will be short saphenous vein, and there will be lymph nodes. Yes.
So which one is the deepest? Superficial.
Popliteal artery is the deepest, madam.
Yes. All right. Can you please tell me the attachment of iliotibial tract, please?
Yes, ma'am. Iliotibial tract is attached superiorly to the iliac tubercle and the iliac crest, and it descends downwards. And as a tract, it gets and attached at the level of lateral part of the tibia, madam.
What are the muscles which inserts into iliotibial tract?
Ma'am, there is gluteus maximus and tensor fascia lata.
Okay. What is the clinical significance of iliotibial tract? Any, if any, can you tell?
Iliotibial tract, its significance is it maintains the knee joint, protects the knee joint in extension and flexion.
Okay.
Stabilizes the knee joint in extension and flexion during walking.
Quickly tell me how many arches there are in the foot and how are they arranged?
Ma'am, arches of the foot are there are medial, lateral, and transverse arch. Medial longitudinal arch, lateral longitudinal, and transverse arch. Medial arch is formed by the muscles, mainly bones. The bones are the talus, calcaneum, navicular, medial form, as well as the base of the first 3 metatarsals. Whereas lateral is formed by the calcaneum, cuboid, and the lateral 2 metatarsals. Whereas transverse arch is formed mainly by the calcaneum and the cuboid. Transverse arch is formed by mainly the base of the metatarsals and the all the
Can
5 base of the
you
metatarsal.
identify, yes, please. Can you identify number 6 over here?
Yes, ma'am. Number 6 is a deltoid ligament.
Okay. How is it formed?
Deltoid ligament, it is the medial ligament of the ankle joint. It is attached superiorly to the superior surface of the medial malleolus, and inferiorly it attached at the level of one is sustentacular tali of the calcaneum, neck of the talus, head of the talus, neck and body of the talus, and the navicular tuberosity.
What are the arteries of the foot, please?
Arteries of the foot are mainly in dorsal aspect. It is the anterior tibial artery, and it is formed by the anterior tibial artery continues as a dorsal superior artery, and it descends down at the level of first metatarsal, and it gives rise to branches between the first and second layer of the foot that is formed by medial and lateral plantar arteries that is found with the posterior tibial artery. So lateral plantar artery joins with the dorsal spinalis artery branch to form the arterial arch of the foot.
Thank you.
Ma'am, 18th is okay.
Starting your timer, and here is your question. Right. So if you have read and understood, consider engage clinical examination station. Kindly begin.
I'll clean my hands. Good morning. I'm Dr. Prabjit, one of the surgical doctor here. May I confirm your name and age?
Nanta, 32 years old. Continue, please.
Thank you. Today I'm asked to examine the swelling in your jaw. May I, this will include looking at it, feeling it, and also doing some tests. Are you okay with that?
Yes.
Okay. So could you point at the site of the swelling for me?
Yes.
Thank you so much.
Below the jaw.
I'm going to see that from front. So I'll see for site, size, shape, scar, skin, and surface. And also I'll look on the other side if there is any asymmetry or any other swelling on the opposite side also. So after that, could you open your mouth for me? I'm going to see it from inside.
Yes.
Could you stick your tongue up? I'll see the floor of your mouth.
Yes, continue.
Now, can you smile like this? I'm going to test marginal mandibular. And after that, I'll ask the patient to stick the tongue out to check the hypoglossal nerve. Now, thank you so much. Now I'm going to examine you from the back. Are you okay with that?
Yes.
Okay. So I will feel your this swelling with my hand. I'll be as gentle as possible. Let me know if you feel pain or discomfort at any moment. Okay. So I'll check the swelling for edges, then surface. I'll palpate the pulsatility, the compressibility, and temperature and tenderness. And also I'll examine the other side at the same time. I will tell the patient that I'm also going to check a few glands in the neck. I'll check for the lymph nodes, the submental, submandibular, the preauricular, the postauricular, the occipital, and also the supraclavicular lymph nodes. So I'll go in the front again. I'll tell the patient that I'm going to examine the patient's oral cavity with my gloved finger. I'll cover up with my hands with the gloves. I will ask the patient to open the mouth once again. So I'll test the floor of the mouth. I'll do this with bimanual palpation. One hand over the swelling from outside, and gloved index finger from inside will be feeling the swelling and also the duct, and I will feel for any tenderness, any stone if present in the duct. And also I will tell the patient that now I'm going to check the sensations or touch on your tongue. For the purpose of letting you know how it feels, I will touch the chest area with my other hand. So it will feel like this. I'm going to test the sensations, and if you it on the tongue, just let me know. You have to close your eyes while I'm doing this test. Could you feel this?
Yes.
So I'll use the glove finger on the tongue and ask the patient every time he or she feels, then he should say yes to that. Okay, so after that, thank you so much. After that, I will see if there is any fluctuation, I'll do the transillumination. And also I will do the auscultation of the swelling, yes, with the stethoscope to check if there is any bruit. Thank you so much. I'll clean my hands again. This completes my examination. I'll come back to you later after consulting my seniors, and we'll get back with the results. So today I examined this 32-year-old female who presented with swelling in the right jaw. And on examination, the swelling was 3 by 3 centimeter. And on inspection, the swelling is smooth, surface is normal. There is no erythema, no scars, and other side is also clear. On examination of the swelling palpation, there is no tenderness. Again, I confirmed my inspectory findings, and the mass is not compressible. And on bimanual examination, I could not feel the mass on the floor. There is, I could not also the stone in the duct. So my provisional diagnosis for this is either cyalolithiasis of submandibular gland or
what are your
tumor
differential
of the
diagnosis?
submandibular gland.
Okay.
Yes, these two,
How would you-
cyalolithiasis and cancer.
How would you confirm your diagnosis?
So I would like to go for cyalogram. I will
Yes.
also get ultrasound of the swelling to check what kind of swelling it is, X-ray of the jaw, if there is any extension into the or erosion of the bone. I can also get a CT scan if it comes out to be or we have suspicion of cancer, and MRI can also be done. These are my investigations. Along with that, I'll
Fine needle
oral
aspiration.
Pardon?
FNAC. FNA. Fine needle
Yes,
aspiration.
FNAC if suspicion of cancer is there.
Okay, so what are the treatment options that you can offer this patient?
If the patient is having pain, the conservative management could be analgesia, rest, and also hydration,
Yes.
along with the massage of gland. We could also go for cyalogram in order to check the patency and any stone in the duct. And it can also be therapeutic sometimes. Stone can move out of the duct with the cyalogram. We can go for opening of the duct and laying it open if there is stone after retrieval, or we can also use a scopy method, cyaloendoscopy, in order to retrieve the stone. For the carcinoma, we have to go for MDT consult and go according to the protocol and type of the tumor. We can go for chemoradio also as a palliative therapy.
Yes, after excision. Good. So, yes, since you completed within Right, so if you have weighed and understood, considering with communication skills station, kindly begin.
Good morning, Mrs. X. I'm Dr. Awarki, the clinical doctor here. I understand that you have been waiting here to do the CT scan. I have come to talk to you about a condition. I have come to talk to you and explain to you what I can do for you.
Okay, you are Mr. Man?
No, I'm Mr. Worky. I'm Dr. Worky, the SHO. I'm working for Dr. Mann. Unfortunately, he has been called out for an emergency surgery, so you won't be able to meet him right now.
Okay.
It's not
So
okay.
I have come
Sure,
to.
Rachel, yes.
Okay. No, I am here to meet Mr. Man. He has ordered for a CT.
I'm extremely sorry, Mrs. X. Mr. Mann has been called out for an emergency surgery, so he won't be able to meet you. I have come to see what wrong and what can I do for you, and I can explain what can I do to help you.
Doctor, my husband is having tummy swelling and they told they'll be planning CT. So first of all, I don't know why this CT is required.
Oh,
Can you
I
please explain
understand.
about this, what it is?
Yes, I'm extremely sorry. I understand that you are going through a tough situation. First, let me explain to you why this CT scanning has been requested. Your husband has been referred by the GP to Mr. Mann few weeks ago, and with the tummy swelling and the fluid. So it was found that his tummy has a certain amount of fluid, and part of that fluid was taken for analysis, and it showed cancer cells, unfortunately. So we are planning to do a CT scan to find out from where this cancer cells are coming and whether it has spread to anywhere else. And to find out that's why we have planned for a CT scan.
Okay.
So that's, yes.
So you are going to get the CT scan done now?
Unfortunately, no, Mrs. X. Our CT scan machine is not working and is under maintenance now. I'm extremely sorry for that.
So now how will we coming to know about the problem?
Please, can you please calm down, Mrs. X? I understand your situation, but I can offer other options. Like we can think of doing a temporary alternative, like an ultrasound scan. You know, the jelly scan we do for pregnant females. Or else another option is to do an MRI scan, which is equally good as CT scan. But the problem is that I need to get Mr. Mann's opinion before doing that. If we do the ultrasound scan, we can know the status of his liver and also see whether there are any spots, any suspicious spots on his liver, and also we can understand that whether there are any what's the amount of fluid is present in his tummy. And if these two options are not possible, there is another option that we can shift your husband to another hospital, transfer him to another hospital to get the scan done.
Okay, then transfer him to some other hospital. If it's small hospital with no proper CT scan, please transfer me to some other place.
Mrs. X, I understand your apprehension. I accept that we are a small hospital and we have not our resources, but usually we try to get all the investigations required for such a patient within a period of 2 weeks. But you need not worry if at any time we feel that your husband, we will not let your husband leave your husband to suffer. If needed, we will definitely transfer him to another hospital.
So you're telling me it's a cancer?
No, Mrs. X, it's not yet conclusive to say that it's a cancer. What we have now only is that his tummy is having fluid, and the tummy fluid analysis showed that there are some cancer cells. But in order to say that it's a cancer, we need further information. like from where it is coming from, whether it has spread to anywhere else, what's the stage, and what sort of treatment we can offer. For that, we need further tests. And the first one among that is the CT scan. So I can't confirm that it's a cancer, but it is highly likely that it's a cancer.
Okay, so you're telling me that he required a surgery for same?
No, surgery is definitely an option for cancers, but in your husband's case, it is it seems that since the fluid is showing cancer cells, it apparently seems that this is an advanced stage of cancer. So in such cases with advanced stage cancers, surgery is most often not very productive, and it is unkind to put such a patient through this suffering and pain of the surgeries.
But he's having problem with breathing. What is about that?
Yes, ma'am. That's probably that's due to the fluid in his tummy, which is pushing on his lungs, and that's why he's not able to breathe. I can discuss with Mr. Mann to remove a certain amount of fluid from his abdomen, from his tummy, so that he will be relieved. And also, there are certain medications which he can prescribe to decrease the fluid in his tummy. That will help him.
Okay, his brother is not here. Can I inform him regarding the situation?
Yes, of course. You can inform him that about your husband's condition. But as I said previously, it's not yet conclusive that it's a cancer, but it is very highly likely that he's suffering from a cancer. But we cannot say from where it is coming until the scan is done.
Okay.
Okay, Mrs. X, since we have come so far, let me sum up what we have been through. You have come with your husband to see Mr. Mann and get the CT scan done. Unfortunately, the CT scan machine is not working. And I have explained to you the other options like doing an ultrasound scan, or an MRI scan, or shifting your husband to another hospital to get the scan done. And I have also explained to you that your husband is probably having an advanced stage of cancer, and he needs to get the CT scan done before confirming that it's a cancer. And also, you said he is having a shortness of breath, which is probably due to the increased fluid in the tummy, and also and the treatment for that can be removal of certain amount of fluid and also certain medications. And Mrs. Mann and Mrs. X, I am extremely sorry, and I apologize again for the inconvenience caused to you. And I will definitely inform Mr. Mann that you were here, and I can arrange an early appointment in the nearest possible time. Any more concerns?
Thank you.
Thank you.
Thank you, Mrs. X.
Good. So I'm starting your timer, and here is your question. Right. So if you have read and understood, considering the clinical examination statement, can you begin?
I would enter the room. I will wash my hands.
Yes.
I am the one of the candidates for this exam.
Yes.
I am. Can I confirm your name and age, sir?
I'm Smith, 55 years old.
Okay. I've been asked to examine your trunk. which includes the front part of your body and the back. And also it would include my inspect your swellings on the trunk, and also, sir, please, can you remove your shirt, please, sir?
Yes.
Okay, just sit properly. Sit on the chair. Okay, first, I will start with inspection. I will then look at the multiple swellings on the trunk. Then I'll also go to the back as well. While checking for the swellings, I'll check for the site of the swellings, the size. I'll measure the appropriate size of the swellings, the shape, the surface, if it is smooth surface or irregular. I'll also check for the skin and any overlying skin changes. I'll also assess for scars. Then I will for the swelling, starting with the
yes, there are multiple
the
swellings. How would you decide which one to examine?
Starting with the biggest.
Biggest.
The biggest of
yes.
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 The biggest.
Yes, please.
Tenderness. I also assess for differential warmth. Then I also check for the surface, which I expect it to be lobulated. I will check for the margins of the swelling. I also assess for the consistency and the surrounding area. I will check for fertility of the largest swelling, and if it is compressible as well. Then I also assess for the regional lymph node.
Yes.
I'll then go to another swelling, which I'll also perform the same. I'll also go for the next biggest swelling, which I'll also perform the same method of palpation, which I palpated earlier. That would include checking for the tenderness, the surface, the margin, the consistency, if it is firm or soft. Then I also check for the surrounding area, if it is pulsatile, and then if I can also reduce it. Then I also check for assess for the regional lymph node. Then after the examination, I will thank my patient, then help him dress up.
Okay, good. So what are your, if you can summarize your examination now?
Okay. I examined a 55-year-old male who presented with I examined a 55-year-old male with multiple swelling on the various sites on the trunk, with the largest located at the back, measured 4 cm by 6 cm. He was hemispherical in shape. It was smooth surface. The skin was, there were no overlying skin changes. He had no visible scars. The swelling was non-tender, had no differential warmth, smooth surface. The margins were clear. It was soft in consistency, lobulated. It was non-pulsatile, and I couldn't compress it. The regional lymph nodes were not palpable. My diagnosis is
so what was the size
lipoma.
of the?
Okay, the size of the largest swelling was 4 cm by 6 cm.
Oh, okay. So what are the differential diagnoses that you'll consider other than lipoma?
I also a sebaceous cyst, then
okay, and
a soft tissue tumor.
Yes, or abscess. So how would you confirm
yes,
your
abscess,
diagnosis?
Then
yes.
My diagnosis, I want to do an ultrasound. Then I also want to do a CT scan, which will help me to check for any bone involvement. Then I also do an MRI. And then if possible, I also want to do a fine needle aspiration cytology.
Okay. What are the treatment options that you can offer this patient?
For this patient, I want to do an excision, which would be the treatment option. Then I will extract the mass and send it for histology, which can also serve as diagnosis and as treatment as well.
Good, thank you. We still had 35 seconds. done. Right, so if you have read and understood, considering a clinical examination patient, kindly begin.
I will enter the room. Hello, I'm Dr. Muhammad, I'm the surgical doctor. Today I have been asked to examine your heart. Also, I would like to examine your hand, legs, and neck. Are you okay with that?
Yes,
Thank you. May I confirm your name and age, please?
I'm Tom, 67 years old.
Okay, nice to meet you. I will reposition the patient at 45 degrees at the couch. Can you take off your gown, please?
Yes,
Help. I will start by look at general inspection. I will stand at the end of the couch. Any the patient there, I will also look for the bedside drugs. Also, I will inspect for any scars, median sternotomy, and also I'll inspect for general patient has respiratory compromise or agitated. After that, I will start by looking local inspection of the hand. Can you stretch your hand out for me, please?
yes,
I will look for any sign of stigmata or infective keratoconus, like the splinter hemorrhage or genuine illusion or ocular node. Also, I will check. Can you put your fingers together like this, please? Looking for clubbing.
yes,
Then also, I would like to assess for the capillary flow. Any nicotine staining. After that, I will assess pulse, radial pulse, rhythm, and character. Like to assess for any collapsing pulse, I will put the palm of the hand on the radial artery pulse. Do you have any pain in your shoulder? I will raise up your.
no, okay, go ahead, continue please.
Okay. After that, I will assess for the artery pulse. I would like to measure the blood pressure. That's okay. Then after that, I will go for the inspection of the neck. Can you tilt your head to the left side, please? I will. Do you have any pain in your tummy? Looking for any raised JVB. That I would like to examine your eyes. I will inspect for any sensitive or corneal arcus. Also, I will inspect for any. Then I would like for any rash over the cheek. Can you open your mouth for me, please? I will look for the oral hygiene of the patients. Can you stick out your tongue for me, please? Looking for any cyanosis or any kind of dehydration, dry mucous membrane. After that, inspect for the pericardium, looking for any surgical scars like clavicular scars. Or can you raise your armpit for me, please? Looking for any scars or median sternotomy scar. Also, I will look for any dilated veins. After that, I will palpate the patient, will locate the apex of the heart. And then from the sternal joint, I will apex of the heart, the middle line. After that, I will palpate for any thrills. The yeah. So mitral and tricuspid or pulmonary, also palpate for any internal heave. I will put the edge of my hand over the left side of the sternum. After that, I will auscultate for the 4 valves area. For the mitral, it will be in the 5th clavicular line of the tricuspid in the 4th. For the pulmonary, in the left side, and towards the 6th right side of the sternum. Meanwhile, I will for the carotid pulse. Then you to the left side to me, please. I will assess for any mitral stenosis by the pulse. Then can you sit up for? Can you take an exhale for any hour? Then I will auscultate carotid fluid. After that, I will auscultate for the basal, any basal crepitations, and also I would like to assess for any sacral edema. After that, I will examine any edema 5 inches above the medial malleolus. Also, after that, I would like to complete my examination by assessing the upper and lower vasculars. You can dress right now. Any help?
Did you look for the leg edema? Yes.
Yes.
10 seconds left. Okay. Okay, can you summarize your...
Do you want any help in your dress?
No, thank you. Can you just
Okay.
summarize the examination now, please?
And of heart failure and also has later. On the general inspection of the patient is not agitated, there is no connective and there is no bedside. And the local inspection of the hands, there is no sign of infective endocarditis. There is normal. I couldn't make the collapsing pulse, couldn't assess that. Don't know the blood pressure, didn't assess it. VB, there is no pallor, and there is no exalsmata or corneal arteries, and there is no cyanosis, no malar rash, and the precord clavicular scars for the most likely to pacemaker implant. This is the apex in this interclavicular space, and there is no any murmur on the examination of limb. There is lower limb edema in both legs.
So how would you confirm? What are your provisional diagnosis?
I mean, provisional diagnosis could be due to heart failure, like crepitation or stenosis.
Can you help me read the ECG, please?
Sorry?
Can you help me to read this ECG, please?
Okay.
How do you intend to manage this patient?
This patient has no B waves.
Okay.
There is
what else is typical?
There is a U shape. Yes. There is a U shape, and there is a QRS, white QRS, and there is
what
the T wave
type
is
of
inverted in
yes,
U shape.
what type of stimulus or what type of ECG is this? Arrow in lead 3 and lead V2. What kind of rhythm is this?
This, this is regular risk.
Did you read here? Patient has a pacemaker. That's why you are doing cardiovascular examination, because patient would be operated for right-sided inguinal hernia, and patient is a heart patient already in mild heart failure with the pacemaker. So now this does not belong to this patient, but this is the ECG of a patient with the pacemaker. And these are the electrically stimulated rhythm. So how would you explain that? How can the
Absent B wave indicate patient has pacemaker implanted.
Yes. So
with
the
white QRS.
Yes. See here in AVL, lead AVL, typical. So you would tell me this tomorrow. Since you are going to operate on this patient, so how do you intend to manage anticoagulant of this patient as well post-operatively?
If patient has high risk thromboembolic at risk, I will stop if the patient is taking warfarin, I'll stop it 4 days pre-operatively. Then I'll convert to the lower molecular weight heparin subcutaneously. I will stop it 12 hours prior to surgery.
Yes.
Also, I will give it low molecular weight heparin 6 hours post-operatively. Then patient should return to warfarin if patient can tolerate oral feeding.
Good, thank you.
If patient has low risk thromboembolic risk, warfarin should be stopped 5 days prior to admission and resume warfarin tabs post-operatively.
Okay. Before surgery, who would you inform about patient's pacemaker?
Yes.
Anesthetic.
Yes, I will call the anesthetic and the consultant.
Good, thank you. Right. So if you have read and understood, considering it history technique,
Dr. Hello, I am Dr. Bharat, one of the surgical resident. May I confirm your age, please?
I am 66-year-old Samantha.
Okay, Samantha. May I know what is your problem?
Doctor, I'm having difficulty in sports these days.
Oh, I'm so sorry to hear that. When did that actually started?
Doctor, I'm feeling difficulty in right now.
Okay. Whether this was there for solid food or it was there also for liquid food?
Now, Doctor, earlier it was actually I had my neck, which is for last 10 years, but I have noticed that it has been increasing for last 2 months, and along with that, the ability to having a food.
Okay, I'm so sorry to hear that. You have said me about your swelling or a lump in the neck. Can you please elaborate about it? Gradually progressing, or it was in the same size since last 2 months it is increasing?
Yeah, doctor. It was not increasing in size, but for the last 2 months it was increasing.
Okay, I'm so sorry to hear that. Do you feel pain along with that swelling?
Yeah, doctor. I told you I had a difficulty in swelling, and I have a pain also.
Okay. Right now you feel the pain. Do you need some painkillers? Please tell me about the swelling. Whether the swelling is appearing in only certain period of time in the day, or it is continuously present?
No, doctor. No, doctor.
Okay. Can you please tell me that whether this pain which was there in the swelling was which type of throughout, or it is only on and off?
Doctor, it is dull aching. It's dull aching pain.
Okay. Do you feel whether the pain is going behind and forward or backward anywhere?
No, doctor. It is there only. It is not going anywhere.
Do you feel anything that can improve this pain or anything that can decrease this pain?
Doctor, I occasionally take some painkillers, over-the-counter painkillers, which my GP has given me. That sometimes helps me in relieving my pain.
Okay. Do you feel this pain is very distressing and it is hampering your daily activities?
Yeah, doctor, it's giving a cosmetic to me also because the swelling is also increasing.
Okay.
I'm not happy, doctor.
I'm
These
so
days,
sorry to
I'm
hear
feeling
that.
I'm on my nerves all the time.
I'm so sorry to hear that. Please tell me about the much bit elaboratively. Do you feel anything which is being stuck in your throat?
No, doctor.
Okay. Do you ever notice any weight loss?
Yeah, doctor, I recently noticed a weight loss. My clothes were becoming loose these days.
Okay. How is your appetite? Have you lost your appetite also?
Yeah, doctor, I don't want anything. Don't eat anything.
Okay. I'm so sorry to hear that. Do you feel any difficulty change in your voice?
Yeah, recently I have seen, doctor, my voice become harsh. I usually sang a lot sang a lot earlier, but now my voice has been changed.
Okay. I'm so sorry to hear about your complaint. Do you feel any difficulty in breathing?
No, doctor, I'm not feeling any difficulty in breathing.
Okay. Do you feel any restlessness or you're unable to go for any hot climates?
No, doctor.
Do you?
No, doctor.
Okay. Do you feel any change in your bowel and bladder habits?
No, doctor. I haven't
Have you
noticed
felt?
anything like that.
Okay. Have you felt recently any increased sweating is there?
No, doctor.
Have you
I
noticed
felt
any
irritability. I felt irritability, but not like that.
Okay. Have you felt you have been increasing sweating?
No, doctor. I haven't experienced any increased sweating.
Okay. Can you please tell much? Have you visited ever GP for any other medications apart from this, or not any other medication?
Yeah, doctor. I told you because I regularly visit my GP for medication. I am hypertensive and do my swelling in my neck, which is for any.
Okay. Have you underwent any surgeries before?
No, doctor.
Okay. Does any members in your family are suffering from a similar complaints?
No, doctor.
Can I ask you what is your occupation?
I am a retired school teacher, doctor.
Okay. Live with?
I live alone.
Okay. Sorry for asking you whether do you smoke or drink alcohol?
No, doctor. I don't take alcohol. I don't smoke.
Okay. Do you have any difficulty in getting up from bed or going for a walk?
Can you
No,
summarize
doctor.
your history now?
Okay. What do you think the most is? Ma'am, I would first would like to finish my exam by asking the most common concern and her cause and the most common concern.
Yes.
So today I have took a history of a 66 years old teacher who came with lump in front neck since last 10
Yes.
years, but have been increasing since last 2 months and associated with pain, with the change in the voice and loss of appetite and weight loss. Almost gave history of 4 pounds. She's and is feeling irritable all the time.
So what are your
On
differential
regular
diagnosis?
medication for
Yes.
blood pressure and from the station. So with the given history, and I will my most probable differential diagnosis would be it's a goiter involving the thyroid gland, and probably in a clinically in a hyperthyroid state.
And any other?
Causing compressive features. It's causing compressive features. It can be a modular goiter of swelling, or it can be a neoplasm of the thyroid gland.
Okay, how do you plan to manage this patient?
Ma'am, I would like to plan basically doing a triple assessment. I would like to do a clinical examination along with history taking. Then I would
Yes.
like to get the basic ultrasound of the neck and FNAC done. Along before that, I will get clinical thyroid status of the patient, thyroid picture. Following this investigations, I would like to get a diagnosis, and I will discuss with the multidisciplinary team regarding the same diagnosis, and I will proceed further.
Why do you think patient is having suppression symptoms? Why might have lump increased so suddenly?
The sudden increase in the lump can be because of one is either it can be a hemorrhage inside a lump,
Very good.
or there can be a anaplastic changes taking place within the existing lump, and it is a long-standing lump, so it can be follicular carcinoma developing in a normal goiter of the gland.
Okay. How do you plan to, or what are the treatment options that you can offer to the patient?
Right now, patient is having some compressive features as well as the toxicosis features. So first, I would like to make her get to youth plan for surgical management to relieve the compressive features. I would plan for an total thyroidectomy after discussing in the multidisciplinary team.
Good, thank you. Thank you.
Thank you.
Yes, please. Begin. Right. So if you have read and understood, considering this surgical and optimization, kindly tell me, if you can tell me what are you looking at, and if you can identify the labeled structure.
This is the CT scan of abdomen in axial view.
Yes.
And
Would you be able to identify structure E, please?
ma'am,
Yes, there.
pancreas, body
Okay.
of pancreas.
Can you tell me the parts of the pancreas, please?
Head, neck, body, and tail.
Okay. Can you please tell me this pancreas, what type of secretion it produces, or what are the cells which are responsible for different production which takes place in pancreas? Hormones?
It has an endocrine, exocrine part, enzymatic secretion for digestion, and endocrine part consists of islets of Langerhans, which consist of alpha cell, which
Yes.
secrete glucagon, beta cell,
Yes.
which secrete insulin,
Yes.
delta cell, which secretes somatostatin, and PP cell, which secrete pancreatic polypeptide.
Good. Can you please tell me the blood supply of the pancreas, please? Blood supply of the pancreas.
Ma'am, head and neck is supplied by superior and inferior pancreatic artery.
Yes.
Yes, ma'am. Head and neck is supplied and body entered by the pancreatic branch of artery. And venous drainage by superior mesenteric vein.
There are three sources of blood supply for pancreas. So, okay, pancreatic branches from the splenic artery. Okay, can you please tell me about the ducts of the pancreas? How many ducts are there and where do they open?
Two duct is mesenteric duct and accessory duct.
Yes.
Major pancreatic duct opens in the major duodenal papilla, and accessory duct which opens in the minor duodenal papilla.
All right, good. Can you please tell me about this another organ? If you can identify, then I can tell you. All right, can you tell me the tail of the pancreas is attached with another organ through different ligaments? How many?
Yes,
Which
ma'am.
ligaments are those?
Tail of the pancreas is attached with the spleen, chi ligament,
Yes.
one is gastrosplenic ligament, Linorena ligament, and phrenophonic ligament.
Yes.
And by gastrosplenic ligament, a spleen attached with the stomach, which consists of short gastric and left gastroepiploic vessel attached with the kidney, left kidney, which consists of tail of pancreas and splenic vessels.
Okay, can you please tell me what are the vessels which are encountered during Whipple procedure?
During Whipple's superior mesenteric artery and vein, superior and inferior pancreatoduodenal artery, gastroduodenal artery,
Yes.
and portal vein, superior mesenteric vein.
Okay. Can you please tell me the surface marking of the spleen, please?
Is constituted with the is situated on the axis of 10 tip along the 10 tip, and which
9th, 10th, and
situated
11th
in
ribs.
9th and 11, 9th
Opposite,
and 11,
yes.
and mostly on the 10th rib, and situated in the left hypochondriac region.
Yes. Okay. So if a patient comes with the hairline fracture of 9th rib of the left hypochondrium, there is suspicion of splenic injury. Then can you please tell me how would you manage the patient? What are the types of splenic injuries one can have? Or the grades of injury?
I'm sorry, I could not understand the question.
A patient comes with a splenic injury or splenic trauma. How would you decide how to manage the patient? Because you would not do splenectomy in all the cases.
Yes, ma'am. First, I have this protocol, and then I have to examine and do some investigation to see the status of the spleen, such as CT scan of spleen to see the grade of splenic injury.
Very good. What are the grades of the splenic injury?
Sorry, ma'am.
Okay.
Can I move to next question?
Yes, please. Can you please tell me the blood supply of the spleen, please? Both arterial
spleen
and
is
venous.
supplied by the splenic artery and
Which is
splenic
the
vein,
branch of?
splenic artery branch of the celiac tract, and
Yes.
splenic vein, which
Drains into?
drains into the portal vein by joining the supremacid.
Very good. Okay. All right. Can you tell me about the Linorena ligament?
Yes, ma'am. Linorena ligament, which attached with the posterior lip of hilum of spleen to the left kidney,
Yes.
which consists of splenic vessels and tail of pancreas.
Okay. Can you please explain this image, please? If you cannot, can you please tell me the structure of the spleen? What are the, what is the white pulp and why does it called the white pulp?
The white pulp is called white because it consists of the lymphatic materials
Yes.
with reticular fiber around the arteries, white pulp, and that pulp consists of the venous sinusoid.
Good. Once you are doing splenectomy, what structure should you worry about?
It's tail of the pancreas, maybe
Yes,
injured
very good.
during
Yes,
splenectomy.
good. Thank you.
Thank you.
Yes, started your timer. Right, so if you have read and understood, considering this communication skills question, kindly begin.
Hello, I am Dr. Kuldeep, one of the exam candidate working for Dr. Man under in Army Hospital. I want to speak to Mr. X, a vascular consultation at another hospital. Can I confirm I am speaking to Mr. Man, Mr. X?
Yes, please. Regarding what? Can you summarize?
Yes, sir. We have we have a one lady, 54-year-old lady, who has diagnosed with a mild diverticulitis, managed conservatively in the form of fluids and antibiotics, and she is improving on that day, on improving on the conservative treatment. But now she is developing a left-sided acute limb ischemia, and patient is having a metabolic acidosis with hypokalemia, and she had a broad pre-ventricular complexes on ECG. We are hoping to transfer the patient under your expert treatment for acute limb ischemia.
Okay. Is it urgent? Can you send tomorrow morning instead?
Sir, it's urgent. I am concerned that patient might lose a limb, so it's urgent to transfer under your expert treatment.
Okay. Do you think that a cardiologist opinion is?
Yes, sir. The cardiologist opinion is we need to require a cardiologist opinion, but after the transfer, because the limb need to be given a first priority to save the limb. It just due to the electrolyte imbalance, which can be corrected conservatively.
What do you think about her presumed diagnosis of diverticulum?
So in the setting of acute limb ischemia as fibrillation, it looks like it can be a mesenteric ischemia.
Okay, so can you please tell, is it necessary to scan now?
Sir, we can scan the abdomen, but as of now, patient is stable from the abdominal side and the abdomen is soft and non. We'll do serial examination. If we find anything, we will do the abdominal scan, sir. We can go for a CT scan if the renal functions are normal.
Okay, could it be mesenteric ischemia?
Yes, it can be a mesenteric ischemia, sir. We can, but the patient is stable from the abdominal side through fluid and antibiotics.
Okay, so what if the renal function is not normal?
Sir, renal functions are not normal. We can go for magnetic duplex scans for the vessels, sir, for the inferior and superior mesenteric vessels.
Okay, how could you manage this case?
Sir, I will correct the hypokalemia. I will correct the hypokalemia. I will correct the metabolic acidosis. I will just start the patient on anticoagulation, sir, and I will require a cardioversion, pharmacological cardioversion.
Okay. What about which type of ambulance are planning to send the patient?
Sir, I will send the patient in a cardiopulmonary resuscitation acute.
Okay, who will be accompanying along with the patient?
Sir, I will accompany the patient with. I will accompany with the patient.
Okay, can send over.
Thank you, sir.
No, one more last question. What would you tell patient's family?
I will consult the patient's attendant and family regarding the condition that patient is having a critical limb ischemia, a critical decrease in the blood supply to the limb, which required urgent surgery in the form of removal of the clot, which is obstructing the vascularity, which is obstructing the blood flow to the vessel. If it is not viable, not sustainable, then we might requires to go.
Okay. And so at the end, you have to summarize it to the consultant that this is what has happened, because here you have to tell what is the new diagnosis as well.
Okay.
What is the
as
new
we have
diagnosis?
discussed, so ma'am, it looked like atrial fibrillation associated with a mesenteric ischemia, leading
Yeah,
to
mesenteric
acute
embolus.
limb ischemia.
Okay, good. Yes.
I will summarize as I have discussed with Dr. X. The patient is having ischemia due to emboli as well as acute limb ischemia in the setting of atrial fibrillation, and he accepted our referral for shifting the patient to under his expert treatment.
Yes.
And I
So
will be
here you
accompanying
will
along with
say
the patient,
that, yes,
along with the advice he has given.
You have suggested to transfer now, and this is what we have discussed so far. So because you are summarizing it to your boss, good. You still had little time left.
Okay, ma'am.
So it just went so flying. You still have 2 minutes anyway. Good, thank you.